Good morning, everyone, and thank you for attending today's Grand Round presentation. Today I will be discussing euglycemic diabetic ketoacidosis, or eDKA, an increasingly recognized metabolic emergency associated with sodium glucose cotransporter 2 inhibitors, commonly known as SGLT2 inhibitors. Although diabetic ketoacidosis is traditionally associated with severe hyperglycemia, eDKA presents differently. Patients can develop life-threatening ketoacidosis while maintaining normal or only mildly elevated blood glucose levels. This presentation will review the pathophysiology, diagnosis, management, psychosocial considerations, and healthcare system factors that influence outcomes in patients with eDKA. On slide number 2, you will see a presentation overview. We will review clinical case, examine disease process and diagnostic findings, discuss management strategies, evaluate current evidence-based guidelines, and explore psychosocial and healthcare delivery factors that affect patient outcomes. The goal is to not only understand the acute management of eDKA, but also the appropriate broader factors that influence prevention and recurrence. Slide number 3, learning objectives. By the end of this presentation, participants will be able to define euglycemic diabetic ketoacidosis, recognize common risk factors and clinical manifestations, explain underlying pathophysiology, interpret diagnostic laboratory findings, develop evidence-based treatment plan, discuss psychosocial and healthcare system considerations, and evaluate current literature and guideline recommendations. Slide number 4 is your case presentation for today. Our patient is a 52-year-old female with a history of type 2 diabetes, hypertension, and obesity. She presents to the emergency department with 2 days of nausea, vomiting, abdominal pain, generalized weakness, and shortness of breath. Her vital signs demonstrate hypotension with a blood pressure of 94/58, tachycardia at 118 beats per minute, and tachypnea with a respiratory rate of 28. Upon physical examination, revealed dry mucous membranes, Kussmaul respirations, and diffuse abdominal tenderness. Several important clues emerge from her history. She recently started a ketogenic diet, had poor oral intake for approximately 48 hours, and experienced a recent viral illness, all the while she was taking empagliflozin. It's very hard to say, so we're going to go by its brand name of Jardiance. These factors significantly increased her risk of developing eDKA. Slide 5 is definition and epidemiology. Euglycemic diabetic ketoacidosis is characterized by classic ketoacidosis triad. This triad includes metabolic acidosis with a pH less than 7.3, elevated ketones, and blood glucose level below 250. Unlike traditional DKA, patients do not present with profound hyperglycemia. According to the CDC, over 38 million Americans currently have diabetes. Although eDKA only accounts for about 2.6 to 7% of DKA cases, incidence has increased substantially due to the widespread use of SGLT2 inhibitors. Common risk factors for euglycemic diabetic ketoacidosis include SGLT2 inhibitor therapy, prolonged fasting, ketogenic diets, which is also very common now, pregnancy, acute illness, and perioperative stress. Slide number 6, the pathophysiology. To understand eDKA, we must first understand normal glucose metabolism. Normally, insulin suppresses lipolysis and ketone production while facilitating cellular glucose uptake. In eDKA, there is relative insulin deficiency. This results in an increased glucagon secretion, elevated catecholamines, increased cortisol production, and activation of lipolysis. Fatty acids are released and transported to the liver, where they undergo ketogenesis. The resulting ketone accumulation produces high anion gap metabolic acidosis. What makes eDKA unique is the effect of SGLT2 inhibitors. These medications promote glucosuria, lowering the serum glucose levels even while ketosis progresses. As a result, glucose levels appear deceptively normal, delaying recognition and treatment. Slide number 7, diagnostic findings. Laboratory evaluation confirmed the diagnosis of eDKA. The patient's glucose was only 186 upon arrival. However, the pH was critically low at 7.18. Bicarb measured 10 milliequivalents per liter, and her anion gap was elevated at 22. Beta hydroxybutyrate and urine ketones were positive. Potassium was initially elevated at 5.3, which is common due to extracellular shifts despite total body potassium depletion. This pattern demonstrates why clinicians must look beyond glucose values when evaluating patients with possible DKA. Slide 8, differential diagnosis. There's several conditions that can mimic eDKA. The classic DKA was considered but excluded because her glucose remained below 250. Hyperosmolar hyperglycemic state, HHS, was unlikely because of significant ketosis was present. Starvation ketosis was considered but generally produces a milder acidosis. And lactic acidosis was possible, but positive ketones supported ketoacidosis. Sepsis was also considered due to the tachycardia, tachypnea, and hypotension, but no infection sources were identified. Toxic alcohol ingestion may also produce high anion gap acidosis, but was inconsistent with the patient's clinical presentation. Before proceeding to slide 9, we're going to have a quick review. 52-year-old patient, history of type 2 diabetes, hypertension, and obesity, on Jardiance, metformin, and lisinopril. Patient has recently felt ill with poor oral intake the past 48 hours. We are ruling in euglycemic diabetic ketoacidosis due to a normal blood sugar level less than 250 in this case. 186 is still elevated, but not enough for traditional diabetic ketoacidosis. Severe acidosis of 7.1 pH and a very elevated anion gap. Because of this triad, euglycemic diabetic ketoacidosis is the final diagnosis, especially with the SGLT2 inhibitor prescribed to the patient. Research says despite a poor oral intake for 2 days, which may include the SGLT2 inhibitor, eDKA is very possible, as this drug can stay in the system up for 10 days. SGLT2 inhibitors continue to produce glucose output in the urine, but with the patient's new ketogenic diet and severe decrease in carbohydrate intake, it seems like the patient is presenting with a high anion gap, low pH, but normal glucose due to the SGLT2 inhibitor. Slide 9, treatment and monitoring. Management principles mirror those of traditional DKA, but require earlier glucose supplementation. Fluid resuscitation begins with balanced crystalloids such as lactated ringers. Balanced solutions reduce hyperkalemic metabolic acidosis compared with normal saline. Continuous intravenous insulin infusions is initiated to suppress ketogenesis. Unlike traditional DKA, dextrose-containing fluids are often required early because the glucose levels are already near normal. Potassium replacement is guided by serial laboratory monitoring. Complications including hypoglycemia, hypokalemia, cerebral edema, and arrhythmias are to be frequently assessed. Frequent reassessment is critical. The patient will be placed in the critical care unit at this time. Slide 10, problem list and management plan. The patient's primary problems included euglycemic diabetic ketoacidosis, volume depletion. This is suspected due to the poor oral intake for 48 hours for her recent illness, metabolic acidosis, electrolyte imbalance risk, type 2 diabetes, medication-related adverse effects, and nutritional deficits. Treatment priorities include aggressive fluid replacement, continuous insulin infusion, potassium monitoring, mag replacement as needed. We also want to watch the calcium and the phosphorus, and dextrose administration to prevent hypoglycemia while continuing insulin infusion therapy. The primary endpoint is closure of the anion gap and resolution of ketosis. Slide 11, current literature. There's a 2022 case report that highlights a particularly important finding. Patients may remain at risk for eDKA even after discontinuation of an SGLT2 inhibitor, which we briefly discussed before. This is highly relevant to our patient. Even if the medication adherence is uncertain, clinicians should maintain a high index of suspicion while evaluating ketoacidosis in patients with recent SGLT2 exposure. The article reinforces the importance of early recognition, sick day education, and thoughtful decisions regarding future medication use. It is important to know that SGLT2 inhibitors are widely prescribed for heart failure patients as well as diabetic patients. Biosocial considerations, slide number 12. Successful management extends beyond correcting metabolic abnormalities. Biologically, this patient has obesity, diabetes, and recent illness. Physiologically, she expresses anxiety and fears in insulin therapy. Socially, she lives alone and has transportation limits. Financial concerns and medication costs further complicate care. Family members have limited understanding of diabetes management, and these factors can significantly influence treatment adherence and long-term outcomes. As we all know, insulin therapy in the United States is very expensive. This might allude to the reason why she's on metformin and Jardiance in the first place. Slide number 13, willingness to participate in care. Fortunately, this patient demonstrated motivation to improve her health. We figured that would be the case. Well, I figured due to her recent diet. So she wants to get healthier. She expressed willingness to participate in education, dietary modifications, and medication adherence and follow-up care. This willingness provides an opportunity for meaningful intervention. Patient engagement is often one of the strongest predictors of successful diabetes management. Slide 14, health promotion and primary prevention. Prevention is essential because eDKA is largely avoidable. Patients should receive diabetes self-management education, emphasizing that DKA can occur despite normal glucose levels. Nutrition counseling should discourage prolonged fasting and unsupervised ketogenic diets. Hydration should be emphasized, particularly during illness. Patients prescribed SGLT2 inhibitors should receive explicit sick day instructions. As we were discussing, poor PO intake, dehydration, etc. They should understand when to monitor ketones, when to hold medications, and when to seek medical attention. This would be a good opportunity for the patient to perhaps invest in some ketone strips to test the urine, and definitely continue to take the blood glucose. If feeling weird, yes, I know the blood sugar can be normal, so with the normal glucose, but ketones in the urine, that might suggest, and any symptoms might suggest eDKA for the patient. Slide 15, consultants. Management of eDKA requires a multidisciplinary approach. Endocrinologists assist with the long-term diabetes management, so hopefully we can refer her to a local endocrinologist if she doesn't already have one. Pharmacists provide medication reconciliation and counseling, especially the SGLT2 inhibitors. Dietitians address nutritional planning. A dietitian in this case is especially important to help the patient to understand why a ketogenic diet is not the best option, but a more balanced diet is. Nurses perform monitoring and reinforce education for the patient. Social workers help address transportation, insurance, and medication affordability barriers, and interprofessional collaboration significantly improves outcomes. Access to care, slide 16. Access to healthcare resources directly impacts disease outcomes. Affordable Health Care Act has improved access to diabetes care, preventative service, and specialist referrals. However, this still remains a challenge despite the fight to decrease insulin costs, medication costs, insurance authorization requirements, and limited endocrinology access continue to create barriers. I know where I live, there is a very big shortage of endocrinologists practicing. Even evidence-based therapies are ineffective and patients cannot attain them. Slide 17, team collaboration. This case highlights the importance of coordinated care. Emergency physicians identified the metabolic emergency. Nurses provide continuous monitoring. Pharmacists assisted with management of the medication. And dietitians and social workers address long-term barriers. I would like to further point out interprofessional teamwork accelerates diagnosis, improves patient education, and enhances discharge planning. That being said, it's important for the nurses at the bedside taking care of this patient to understand the difference between euglycemic DKA and typical DKA, as they might not be used to implementing that dextrose infusion along with the insulin right away. Some of them are very used to the traditional DKA, where you start the insulin and hold the dextrose until you reach a certain glucose level. So it's important to tell the nurses that there is a reason we're continuing to do insulin and dextrose immediately upon admission. Slide 18, healthcare delivery site. The type of healthcare institution greatly influences patient outcomes. Academic centers often provide greater access to endocrinologists, diabetes educators, and specialty consultation. I'm sure we all know this from experience. For-profit hospitals may invest heavily in advanced technologies and monitoring systems, whereas public hospitals frequently care for vulnerable populations with significant social determinants of health. Regardless of the setting, prompt recognition and evidence-based protocols remain essential. Slide 19, follow-up and evaluation. Immediate treatment goals include resolution of acidosis, closure of that anion gap, and stabilization of electrolytes. Long-term follow-up should include endocrinology consultation within 1 week, medication review, and serial A1C monitoring every 3 months. Success is measured by avoidance of recurrent DKA, improved diabetes knowledge, and sustained treatment adherence. In this case, it is very important to obtain a patient's A1C because moving forward, restarting that SGLT2 inhibitor may not be the best option for the patient, as this patient's at a risk of going back into euglycemic DKA. Slide 20 is evidence-based guidelines. Current ADA recommendations emphasize rapid fluid replacement, insulin therapy, IV drip, electrolyte management, identification of precipitating factors, and discontinuation of the offending SGLT2 inhibitor during the acute episode. These recommendations form the foundation of modern eDKA management while maintaining a normalized glucose with that insulin. Slide 21, why is this best practice? Why is this the best plan of care? This plan both addresses the immediate and long-term concerns. It corrects the ketosis, dehydration, and electrolyte abnormalities while reducing recurrent risk. The patient's A1C will help determine future diabetes management. Because obesity remains a major concern and the patient is motivated to improve her health, consideration may be given to transitioning from an SGLT2 inhibitor therapy to alternative agents, such as another SGLT2 or even now the GLP-1 receptor agonist. One important management decision in this case was selecting the lactated ringers rather than normal saline for initial fluid resuscitation. This can be a hot topic. Historically, normal saline has been used as the standard fluid management in DKA. However, growing evidence suggests balanced crystalloids such as lactated ringers may be superior. Normal saline contains a chloride concentration of approximately 154 milliequivalents per liter, which is significantly higher than the plasma chloride levels. Large volume administration can produce hyperchloremic metabolic acidosis, potentially worsening acid-base disturbances already present in DKA. Given that the patient is of younger age, does not have a history of heart failure, the patient will be receiving a large amount of fluids to help resolve this issue immediately and rehydrate the patient. Lactated ringers contains electrolyte concentrations that more closely resemble plasma and contains lactate, which is metabolized into bicarbonate by the liver. A lot of people fear because of the lactate, the patient will become more acidotic, but that's not necessarily true. Several studies, including the SMART and SALT-ED trials, demonstrated improved renal outcomes and less hyperchloremia with balanced crystalloids compared to normal saline. For patients with eDKA, where metabolic acidosis is already profound, avoiding additional chloride burden may facilitate faster correction of acidosis. Key takeaway is the balanced crystalloids such as lactated ringers are increasingly preferred for DKA management and eDKA management because they avoid worsening metabolic acidosis and may improve renal outcomes. Slide 22, barriers to implementation. Several barriers could interfere with the success of the patient, both acute and long-term. Patient barriers include medication costs, transportation limitations, and health literacy deficits. Luckily, our patient is pretty engaged and willing to learn. System barriers include specialist shortage, insurance delays, and limited diabetes education resources. Potential solutions include telehealth visits, social work involvement, medication assistance programs, and community support resources. The American Diabetes Association continues to recommend SGLT2 inhibitors for many patients because of their substantial cardiovascular and renal benefits. These medications have demonstrated reduced heart failure, hospitalizations, slowed progression of chronic kidney disease, reduced cardiovascular mortality in selected populations, and effective glycemic control. However, providers must remain vigilant regarding eDKA risk with these SGLT2 inhibitors. Patients prescribed these SGLT2 inhibitors should receive routine counseling regarding sick day management, ketone monitoring, adequate hydration, and recognizing the symptoms of eDKA such as nausea, vomiting, abdominal pain, and shortness of breath. The ADA emphasizes the benefits of these medications often outweigh the risks when patients are appropriately selected and educated. SGLT2 inhibitors remain highly valuable medications, but patient education is essential to prevent eDKA. Now, the big question is should the patient continue with the Jardiance once they're recovered and being discharged from the hospital? This frequently generates questions among providers, and there is no universal answer. The decision should be based on cause of the eDKA, future recurrent risk, glycemic control, cardiovascular benefits, heart failure status, and kidney disease status. You would want to restart the Jardiance if there's excellent cardiovascular benefits for the patient, reduced heart failure hospitalizations, and renal protection. Arguments against it are prior eDKA episodes. This makes the patient's first one, ketogenic diet preference, poor adherence to sick day recommendations, and high reoccurrence risk. For this patient, the episode was likely multifactorial with Jardiance use, the ketogenic diet, the acute viral illness, and reduced oral intake. If these risk factors can be modified, restarting may be reasonable after endocrinology consultation. However, there are many alternative therapies, especially for this patient who seems motivated about weight loss, which might ultimately help with hypertension and diabetes diagnostic. Key takeaway, a previous episode of eDKA is not an absolute contradiction for restarting the SGLT2 therapies, but careful risk-benefit assessment is required with these patients. Slide 23 is our reference page. Several cited articles and evidence-based research. Again, the SMART trial and the SALT-ED trial go through the therapies for DKA, the fluid therapy, So in conclusion, euglycemic diabetic ketoacidosis is an increasingly important diabetic emergency that requires heightened clinical awareness. The absence of severe hyperglycemia often delays diagnosis. Providers must recognize the association between SGLT2 inhibitors, ketogenic diets, illness, and fasting. Early recognition, aggressive treatment, patient education, and multidisciplinary collaboration are essential to improving outcomes and preventing recurrence. Thank you for your time. I will be happy to answer any questions. Thank you.